what is spirometry? Basically, spirometry is how fast and how much air a patient can blow out when they're trying as hard as they can. The problem with spirometry is that we're asking the patients to do something that they most likely have never done before. They have to take their biggest breath, pack in as much as they possibly can. They have to blow as hard as they possibly can for as long as they possibly can. 3 things that's likely they've never done. This slide is showing the volume time curve, also known as the spirometry curve. Spirometry is broken into 2 parts: spirometry, which is the volume time curve, and the flow volume loop. I like to show my medical students when I teach this course how much the diaphragm is doing when the spirometry is happening. What we're looking for on the volume time curve is to assure that the patient blew for a minimum of 6 seconds if they're an adult. You can see time is on the x-axis and the volume, the vital capacity, is on the y-axis. We're also looking for the volume time curve to plateau. How we measure the FEV1 and the FEV1 over FVC ratio is by looking at the volume time curve. We see the first second. In this particular case, the person had blown 4 liters of air out in the first second, and by the end of the blow, 6 seconds, they had a total of 5 liters out. If you make the ratio 4 over 5, that says 80%. This patient got 80% of their air out in the first second, and if it's a younger person, this is a perfectly normal spirometry. The flow volume loop is where we actually look for diagnostics. The shape of the flow volume loop changes with different types of lung disease. The flow loop is really a graph that represents how fast the air comes out of the patient. Keep in mind, airflow rates are proportional to the size of the tube. In this way, what I'm talking about is the airway diameter, or the average diameter of the bronchial tree. In an acceptable flow loop, there has to be a rapid rise, a peak at the top, a smooth, continuous curve back to baseline. What I mean, there can't be any cough, glitch, stop, or pause in the flow volume loop. Spirometry is about measuring how fast the air comes out of the patient. That's how we decide if somebody has obstructive airway. Obstruction means the air is coming out too slow, right? They take their biggest breath, they blow as fast as they can. If the air comes out too slow, in other words, if the FEV1 over the FVC ratio is below the lower limits of normal, that's the definition of airflow obstruction. We like to use the rule of thumb is if the FEV1 over the FVC is down 10 from what's predicted, we say that the patient has airflow obstruction. We're also looking at how much. This is how we determine if there's restrictive disease. If the vital capacity, the forced vital capacity is too low, we wonder if there's possible restriction or restrictive lung disease. Obstruction is too slow. Restriction is too small, not enough vital capacity. The important variables that we talk about during spirometry is the FVC, or the vital capacity, forced vital capacity. The FEV1 is the amount of air that comes out in the first second. The all-important FEV1 over the FVC ratio, the ratio is what determines if a patient has airflow obstruction. This is really important because 80% of the abnormal pulmonary function is obstructive lung disease. Notice that the ratio has a wide range of what's normal. An elderly person, a normal ratio is 70. A young child, say a 5-year-old, the normal ratio is 95. What that means is a little kid can get 95% of their air out in the first second. But an older person, normally can only get about 70%. A good spirometry can tell you a lot about this patient. If they have normal flow rates, and normal vital capacity, we can say normal spirometry. If the flow rates are reduced, in other words, FEV1 over FVC is below the lower limits of normal, we can say the patient has airflow obstruction. And then the American Thoracic Society has a grading system for mild, moderate, severe, and very severe airflow obstruction. Now, if the flow rates are normal and the vital capacity is reduced below the lower limits of normal, we make a mention that there's possible restriction. The reason why we can only say possible restriction is because when patients have significant air trapping in obstruction, they will have a low vital capacity as well. And so a low vital capacity, what we say, possible restriction, further testing is needed to confirm. I want to thank you for joining the American Lung Association.